Good afternoon, everyone. We'll go ahead and get started now. My name, if you haven't met me before, is Jack Jager. I'm the Executive Director of the Rural Health Innovation Collaborative located in Terre Haute. Me and my team have been coming to your hospital over the past 6 months or so, and we've very enjoyed that. And now we're in the middle of this COVID-19 situation, and obviously what we'd like to be doing right now is coming to your hospitals and completing the second set of trainings with each of you on your chosen topic. But because of the situation with COVID-19, we're having to change things up a little bit and go virtual. And so we're planning to do 4 of these virtual trainings over the next week. Today we'll be talking about stroke assessment. And then next week, on the 22nd, we'll be doing one on neonatal emergencies and neonatal resuscitation and stabilization. The 28th, we will be doing one on pediatric emergencies. And then on May 29th, we'll be doing one on adult dehydration and hypovolemia. So today's topic is stroke assessment. And the way I'd like to start this, if you could, please open up your chat. And if you would, please put in your name and what hospital you're coming from. That would be very helpful. And then in addition with the chat, if you would like to ask any questions along the way, please just pose those in the chat box until we get to the actual debriefing of the virtual simulation we're going to do on here. And then we'll maybe have you ask questions to the rest of the group that way. So there are a number of people that have been involved in the creation of these videos. Today's video is about stroke assessment, and the primary person that's going to be doing the presentation today is Suzanne Wheeler. She's a clinical nurse specialist from here in Terre Haute, and she's had extensive experience in critical care and several other areas of the hospital. She's worked at several hospitals across multiple states in her career, and she's just really a gem to be able to work with, and she's exceptional to have on our RIC team. And so if you remember when we came for our first training, we mentioned that this project is part of the Indiana Hospital Association's SHIP program, and it's the Indiana Small Rural Hospital Improvement Grant. And this cohort for this year is using simulation to promote patient safety. And so we will be doing this continuing through the next 4 years with different hospitals each year. And so we're coming to the end of our year with your hospitals, and hope you've had some good experiences from working with us. We know that we've loved every minute of coming to your places and seeing what you do at your really exceptional small rural hospitals, critical access hospitals in the state. As you probably also know, this is a collaborative effort between the 3 entities you see here, the Indiana Hospital Association and the Indiana State Department of Health. And the RIC has been contracted with them to provide simulation-based training for each of the hospitals in our cohort over this 4-year period. And it's been really great to work with the Office of Rural Health through ISDH and the great folks at IHA. If you have any questions moving forward after today or any time into the future, we're very much willing to talk to you. The 3 primary points of contact are myself, Laura Livingston, our clinical simulation specialist at the RIC Simulation Center, and then Suzanne Wheeler, our project consultant. And you see the contact information listed there. And I can share this again at the end if you'd like to have that. Today's agenda, this will probably take about 2 hours or so, maybe a little bit longer. And once we are done with this video is being recorded, so you can come back and look at this or share this with other folks. We will share the link to the video recording with all of your hospital leadership so that it can be shared with other people in your facility. We're going to start with a pre-course test, and I'm going to share that information for you to get on and do that pre-course test here in a second. After that, we will start with a presentation on the NIH Stroke Scale that Suzanne will complete. And then following that, we will do a virtual recorded simulation that we completed. And with that, I want you to pay attention to the simulation, but then also start thinking about questions that you would like to ask during the following stage, which is our debriefing of that simulation, which we'll do immediately following the video. At the end of it, then we would like for you to take a post-course test and a post-course evaluation that I'll share with you on the screen at that point. So right now, what I'd like to do is go ahead and have all of you take our pre-test, and you can do that in several different ways. You can, if you have the ability with a smartphone to scan a QR code, you can just take a picture of that QR code and go to the link that way, or you can copy this pre-test URL link above that and go take the test. And we're going to give you about 5 minutes to do that. And during that time, I'm going to go ahead and pause the recording, and we'll get back with you in 5 minutes. So go ahead, and then at around 1:12 or 1:13, I will get back on and we will start the presentation. So go ahead and take the pre-test if you would, please.
So course objectives, we're going to talk about the National Institute of Health Stroke Scale, its purpose, the elements, and also demonstrate the individual components. Okay, next slide. So what is the NIH Stroke Scale? It is a standardized test that was developed back in the 90s to see if it was safe to give patients with ischemic stroke thrombolytic therapy. So it was developed for clinical trials, originally developed for research. And that's why sometimes when we're administering it, it can be kind of confusing, because you may be thinking, oh, I want to check their pupils for size, etc., or do a Babinski or different things, but those aren't included here. And that's because they were trying to find things to check that were reproducible and gave them the greatest information about severity of stroke. So keep that in mind. It is the gold standard for the 2018 stroke guidelines from AHA, and Joint Commission and HFAP. Whenever you're getting stroke certified, this is part of that process for being a stroke center. I think pretty much everyone around the country does, and even internationally, does the NIH Stroke Scale, and it does describe those neurological deficits. So what does it help us do? It helps us quantify our exam so we can talk to each other about what's going on with the patient. So we have a number, in other words, to put to it. Helps track patient changes over time. It's really a great baseline tool. They have, through research multiple times, looking through chart reviews and reviewing cases, have shown that it can be predictive for patient outcomes. Okay, JJ, next slide. It has 11 items on it. The minimum score is 0, so if you get a 0 on the stroke scale, essentially you're not having a stroke, according to this scale. Again, this is not the end-all be-all, but it is very good at what it does. Maximum score is 42, although that's impossible really to get. A patient in a coma, I think the most that they can get is a 39, so a 42 is pretty unlikely. You may see UN or a 9 or sometimes an X on your assessment sheets, and that means untestable. There's only a few reasons that an item would be untestable, but anything untestable is not added to the total, and we'll talk about that as we go through the elements. Through multiple studies, again, this test has been around for a long time. The higher the number of the scale, the higher associated neuro impairment. It can also be used as a kind of a guide, again, as part of the rest of the assessment and the rest of the information, kind of can help the provider decide, what to do. But it's not a substitute for a comprehensive neurological exam. what we should do with the NIH Stroke Scale is use it for what it is, a very good, reliable tool to let us know our patient is having a stroke. So we want to do it the same way as it is basically prescribed. And we want to do it the same way every time on every patient. Okay, let's go to the next one. Okay, JJ, the next one. So here are the rules for the NIH Stroke Scale. I've got the complete list at the end of the resources, at the end of the PowerPoint, just for your information. But essentially, in order for us to get a reliable test score, we want to go administer the elements in order. This is a situation where you don't have to have this memorized. In fact, it's probably best that you don't try to memorize it. You want to use your scoring sheet and go one step at a time. Take a look at what you're assessing, assess it, mark the score, go to the next one. First response is usually the best, so you want to try to go with the first response when you can, because that is typically the most reproducible response. Sometimes it's not possible, but we'll talk about that as we go through. Don't coach the patient unless instructed. There's not very many instances where coaching or cueing applies, but sometimes if you have a patient that is aphasic or has severe slurred speech, you may ask them to write something for you, or you may need to pantomime to them and show them how to do it by demonstrating without words. And we've all had those patients before where, you know, they're looking at you, but they're not doing anything that you say. And so you smile at them and then they smile, or you stick out your tongue and they stick out their tongue, or you put your fingers and you show them how to squeeze and then they about break your arm or your hand. So you've got to show them sometimes. The other thing to remember is this doesn't assess signs and symptoms of stroke. And so keep in mind, you're going to get to that too. You may already have some of that information accumulated before you start the stroke scale while you're getting those items ready to roll. And you'll see in the simulation that the patient in the simulation, at the end of this presentation, we're going to show you the virtual simulation. The patient was having a really bad headache. And then she had some other problems. And so that then triggered some more assessment and then calling the code stroke or the stroke alert. And we started the stroke scale. So you want to do it as soon as possible for any patient having acute changes that may indicate a stroke. Some items on the stroke scale are only scored if present. So if the patient does not have limb ataxia, if they're in a coma, you cannot assess limb ataxia. If they have comprehensive aphasia and they cannot understand you, you may be able to help them just by moving them around and kind of showing them or demonstrating. But if they can't understand at all, you can't really score them as having it if they can't understand you, if that makes sense. Record what you see, not what you think that you should see. And I don't know about you guys, but over the years, I've had very few patients that there was always kind of that, you know, are they ignoring me and kind of playing possum? Don't even think about that. This is a situation like most of the work we do at the bedside. We're not judging, we're not overthinking. We're doing the test and we're recording what we see. Okay, JJ, next slide.
She's a nice girl.
Okay, next slide. Okay, so now we're going to start going through the different elements of the NIH Stroke Scale. And I'll probably call it a stroke scale from here on out because I'm having some slurred speech saying that. Sorry about that. So the first element contains 3 components. I think we need to go back a couple slides, JJ, to 1A. Level of consciousness is the first one that we look at with the stroke scale because you can usually tell this one when you walk in the room. It's our easiest one. Sometimes it's more difficult. We'll talk about that. But as you're going into the room, you're asking questions, you're introducing yourself, you're doing your AIDIT, and you're looking at your patient the whole time. You know, are they looking at me? Are they hearing me? Are they tracking me? How are they responding? You're usually asking them right away how they feel. And then, of course, we always check their name badge and ask what their name and date of birth is and those kind of things if they're having pain. That's how you can assess level of consciousness and score it on the stroke scale. So this is a exception, because usually when you start your stroke scale, you know the answer to this one already. It assesses only alertness and responsiveness. So if the patient's alert, they get a 0, which is good. If they're alert, but they're not alert, but they're drowsy, so maybe you have to say their name or then maybe touch their arm, then they wake up, okay? So that's a 1. A 2 is scored if the patient is not alert and is obtunded. In other words, you have to keep stimulating them to get them to pay attention to you. This may be loud voice. You may have to do some painful stimulation. I usually start off nice and kind of work my way up to the more noxious stuff. So I'd come in the room and try to get eye contact and say their name repeatedly, maybe say it louder, try to get in their line of vision. And also then you would start touching, maybe moving their hand around gently, maybe giving some simple movement to see what happens. But you would score this for any patient that it really takes repeated stimulation for them to pay attention to you. They're just not very alert at all. And they may have very little response, but they may have some purposeful movement. So let me give you an example of this for the patient that's pretty obtunded. And you just keep, touching their shoulder and saying, wake up, wake up, wake up. How are you feeling? I'm your nurse, that kind of thing. And maybe they open their eyes and look at you and then go back to close their eyes and not paying any attention. If they moved at all right there, that's a 2. If when you do all these things and you cannot get any response at all, that is what the definition of a coma is. So your patient, if they're a 3, they are in a coma. That means they're unresponsive, they are not alert, they're not appropriately responsive. The only thing that you might see in a 3 is posturing. And sometimes these folks are completely flaccid. So then that would be a 3. So now we're going to go to the next slide and talk about the second sub-element of level of consciousness. Okay, JJ, next slide. So 1B assesses orientation. And you only want to ask these 2 questions. What is the month and what is your age? That must be correct for them to get credit for this. If they are understanding that are having difficulty speaking, maybe because they have an ET tube in, that would do it. Or maybe they have some kind of facial trauma, or maybe they have severe dysarthria and it's very difficult for them to speak, or maybe they have a neuromuscular injury like ALS or something like that and they cannot speak. Give them a piece of paper to write on, and they get credit for that if they write the correct month and their correct age. If they answer both correctly, that's a 0. If they answer one question correctly, in other words, they are not able to speak, but they can write, or they can speak and they get 1 right, that's a 1. So your patients that are intubated, etc., that's an automatic 1. But you can still have them right. If the patient is completely comatose, that's a 2. Or if you cannot get any information out of them about these 2 questions, then that is also a 2. Again, you don't want to add additional questions here. Just ask, what is the month and how old are you? Folks that are having a brain injury, oftentimes the more you speak, the more difficult it is for them to understand. And this is a standardized test, so we are only measuring these test items during this particular assessment. Okay, next slide. Now the final 1C assesses commands. So this one only takes a look at whether or not they can follow your instruction or follow your commands. You can ask them to shut their eyes and then open them if their eyes are open, or you can have them open their eyes and then close them if their eyes are shut. So this is the example where you are basically not testing strength here. You're testing whether they are able to follow your commands. So you're still looking at level of consciousness in that respect. So you say open and close your eyes. Then you put your fingers in one of their hands and you say grip and release my hand. And then you do the other one. And if they have some paralysis or weakness, then you would still give them credit for performing the grip. So you're doing 2 tasks, open and close the eyes, grip and release, at least one hand. If they can't do either hand, then you can substitute another one-step command. So like stick out your tongue or raise up your arm. I often have said, can you move anything? Just make it a very simple command, not a lot of words, in other words. So the way you'd score this in, if they're alert and following your commands, you'd give them a 0 for doing both things correctly. If they do one task correctly, you can give them a 1. So maybe they squeeze your hand, but they won't do the eye thing. You will give them a 1 for that, even if their grip is weak. If they do neither of these tasks correctly, either because they can't understand or they can't follow commands or they're in a coma, then you would score them as a 2. And at the bottom, I have just a couple tips. Try to score the first attempt if possible and give them credit for trying. Again, you're not testing strength of grip. You're testing whether they understand what you want them to do. You can use pantomime in this one. So if you have a patient that is aphasic and maybe they're having difficulty comprehending the instruction, catch their gaze or make eye contact and then squeeze your eyes shut and open them and see if they will do it back to you. Pantomime just means gesture without words. So you're just showing them, taking away that verbal component, which, as I said, when you're brain injured, that can be confusing for them. You can also put your fingers in their hand and have them say squeeze. You can show them what you mean by squeezing their hand gently. Okay, next slide. So that's the end of level of consciousness. 3 separate assessments for level of consciousness. All must be scored. They are never untestable. Okay. Again, if the patient's in a coma, you can see you have for 1B and 1C, you give them a 2 automatically. And for 1A, if there's some movement, you give a 2. And if they're flaccid or no movement and they're in a coma, then that's a 3. Okay, so let's go on to best gaze, which is our second full element. In best gaze, we're trying to check horizontal eye movement. Horizontal eye movement is a type of extraocular movements. And we're not going to check all the extraocular movements, just the ones in the horizontal field. So back and forth from right to left and left to right. So you ask the patient, follow my finger with your eyes. Sometimes I'll use a pen light, not with the light off, if I think that seems to get their attention better. You may need to, again, get eye contact with them. If they won't track your finger from left to right, from side to side, and it doesn't matter which way you go, sometimes it's better if the patient, depending on what side you're on and how it works out, etc. But you can also have them track your face. If they're not tracking your finger, you can get eye contact and say, and just kind of go back and forth in front of them and see if they watch you, or go around the bed and see if they watch you from left to right. If the patient is comatose and unresponsive, then you can use the doll's eyes maneuver or the oculocephalic maneuver to assess for horizontal eye movement. Now, in this situation, you're not assessing for doll's eyes. What you're assessing for is whether their eyes move back and forth when you turn their head from side to side. Whenever you do doll's eyes, of course, you always want to clear the C-spine first. Hang on to your ET tube and watch all your lines, etc. Explain what you're doing with your patient, and then very gently hold their eyes open and support their head and neck as you gently turn their head from left to center to right to center. And you can go the other direction first if you want. It doesn't matter which way you go first. And what you're looking for is for those eyes to lag behind whichever way you're turning the head. That's normal. And you can score a comatose patient as 0 if there's normal eye movement during this maneuver. Again, you're not trying to figure out whether they have doll's eyes or not. You're trying to find out if their eyes are moving horizontally or not. If when you're doing this test, the patient has normal eye movement, whether they're awake and alert or whether they're in a coma, you give them a 0. If whenever you're doing this assessment and one eye stops or both eyes stop partially, or maybe one eye goes one way, one eye goes another way, you would give that a partial gaze palsy or a 1. And if the patient has their eyes fixed, maybe pointing one way or the other, and you'll see this sometimes in folks that have a large cerebral artery lesion, their eyes will point, sometimes they will have deviation toward the site of the injury, and you'll see that sometimes. And that would be scored as a 2. If the patient, when you do the doll's eyes, if you do the doll's eyes maneuver and their eyes are stuck one way, that would also still be a 2. Whether it's a deviation or whether the eyes are not moving at all, you would still give them a 2. So this is an exception to the first response rule because you have to initiate in different patients. The alert and oriented patient, this isn't going to be a problem because they can understand you. But the person that has aphasia is confused, difficult, it can be challenging sometimes. It may take a little bit of time to try to find out if they have horizontal eye movement. So now we're going to go to a YouTube video from the Stroke channel where you can see they're demonstrating this maneuver. Okay, JJ, you can start the video anytime.
The patient is given a target to follow so that we can examine the full range of horizontal gaze. As the patient demonstrated normal horizontal gaze in both directions, this is scored 0. This time, the patient does not follow the target towards the left, but there is normal rightward gaze. These findings represent a partial but not total gaze palsy, and so the item is scored 1. On this occasion, we're testing rightward gaze, and we see that there is a partial gaze palsy in this direction. This also represents a partial gaze palsy, and the item is scored 1. On this occasion, the patient has a forced gaze deviation to the right, and no eye movements are seen. Because there is a forced gaze deviation, the item is scored 2. In the patient with altered mental status, the oculocephalic or doll's eyes maneuver should be performed. In this case, we see the eyes moving in the direction opposite that of head movement. As the eye movements appeared to be unrestricted with the oculocephalic maneuver, this item would be scored 0. Care must be taken in performing the doll's eyes maneuver in intubated patients or patients with cervical spine precautions. To review, here are the correct levels as shown in the doc flow sheet. If there is partial limitation of eye movements, score a 1. If there's complete absence of eye movements or a forced gaze deviation, score a 2.
Okay, so we'll go back to the PowerPoint slide and we'll talk about the next test. And that is number 3, which is visual fields. Okay, visual fields, we're going to try to see if the patient has blindness in any of the 4 quadrants on both of the eyes. And I will just give you a warning, I really have a hard time saying hemianopia, but I will try. I may just say blind. That's what hemianopia means. You're not, basically you're just trying to see if they can see out of those quadrants. You're not trying to see if they can count or anything like that. What you're trying to find out is if there's vision there. So you test the 4 quadrants of each eye separately. And if the patient's in a coma, you can hold their eyes open and test them using visual threat. And in the video, he will show that, he will give you an example of what that looks like. So how do you score it? If the patient has no blindness at all, no visual field deficits in any of those quadrants, again, 4 quads on each eye, then that's a 0. If the patient's in a coma and you do the visual threat and they blink in all of those quadrants, then that would be also scored as a 0. A 1 is when there is a partial loss in at least 1 quadrant. And a complete, or a 2, is when they're blind in half of a visual field of 1 or of both eyes. And you can see the first picture there to the right, where half of their visual field is blocked out. The blackout part means that that's where the blindness is at. And then the bilateral is for the patient that is completely blind. And there's no blink to visual threat or anything. So 3 is for patients that are blind or who are not responding to any kind of visual threat. Okay, so we'll go ahead and take a look at a video now, again from the Stroke channel, and he'll show you this.
The patient is asked to look at the examiner's nose and is given stimuli in each of the 4 quadrants of the visual fields. In this case, the patient responded normally in all 4 quadrants, so the item is scored 0. Here, the patient fails to respond in the upper left quadrant, but does respond in each of the remaining 3 quadrants. This represents a partial hemianopia, and the item is scored 1. On this occasion, the patient fails to respond to stimuli on the left side, but the right side appears to be normal. This represents a complete hemianopia, so the item is scored 2. On this occasion, there is no response of the patient to stimuli in any of the 4 quadrants. This represents bilateral hemianopia or blindness, and the item is scored 3. In the patient with altered mental status or language disturbance, visual fields may be tested with the blink to threat technique. The examiner's hand is carefully advanced to the eyes from the outer aspect of each quadrant. In this example, there was an intact blink response to visual stimulation in all 4 quadrants, and so the item would be scored 0. To review, here are the levels as shown in the doc flow sheet. If there is a deficit in 1 quadrant, this is a partial hemianopia and scored 1. If there is a complete hemianopia, lack of response on one side, this is a 2. If there is no response in any quadrant, this is scored a 3.
Okay, so that is assessing number 3, the visual fields. And again, we're not seeing if they can count. We just want to know if they can see. And they can point to the side of the movement. They can tell you right or left. You would give them credit for that as well. Okay, so we're ready to go to the next test, or the next element of the test. Facial palsy. So now we're going to assess for facial movement. And this assesses the muscles of facial expression that are supplied by the facial nerve. So you're going to ask the patient to show your teeth. And then when they show their teeth, you're going to see if there's any change from one side to the other. And you're basically looking at that lower part of their face for this one. And then when they raise their eyebrows, you're trying to, again, check for symmetry and movement. And you're comparing both sides. And then ask them to squeeze their eyes shut and then open them. So you do those 3 tests, kind of pause in between and observe. And you can pantomime this one as well. You can show them what you're trying to say. I always had the impression the patient thought I was insane when I was doing this to them. So, but it helps because sometimes they will respond to you. Now, if they're confused or nonverbal or they're in a coma, you can use, for a coma, you're going to give them an automatic 3. But if they are nonverbal or confused, you can use noxious stimuli to get to see if they will make facial movements, and then you can rate them based on that grimace. Again, what we're looking at only here is facial movement. So a 0 for a symmetrical movement of the face, which is normal. You would score it as a 1 for minor facial weakness. So you have the patient show their teeth or basically smile, and you see some asymmetry. It's not real, just obvious as heck, but there's something different. That would be a 1. If they show their teeth and it's pretty obvious, they have major asymmetry, that's a 2. Or they raise up their eyebrows on one side, there's no movement at all, you'd give that a 2. And we'll show you some pictures of this in just a minute. And a 3 is for that patient, again, who's in a coma, because they can't follow your commands. So that's why you go ahead and score that as a 3 for a patient in a coma. But otherwise, if they have paralysis on one or both sides, or there's no movement at all, then you would give that a 3. So we'll take a look at a couple pictures. This first picture on the next slide. Okay, JJ, you can go ahead and cue up a picture. This is a real case study that was done in Turkey by Odin and colleagues in 2017, and they published this. This is a patient having an acute frontal stroke. And you can see that they're requesting her to squeeze her eyes shut and smile and those types of things. And you can see she's got a pretty severe facial asymmetry. Okay, the next slide also shows another picture. It's hard to get it's hard for us to simulate a facial palsy. So that's why we have some pictures to try to help us remember, because I find this challenging as well, especially telling the difference between Bell's palsy or peripheral palsy and central palsy, which is what we're having when they have an acute stroke. Now, do you need to know the difference at this point when you're doing your stroke scale if it's Bell's palsy or acute stroke? No. All you want to know is whether they have asymmetry or lack of movement on either or part of their face. But I did put this on here just for your own information about what the difference is between the central palsy or the peripheral palsy, which is what the Bell's palsy is. Okay, next slide. We're going to go on to the next element. Oh, by the way, before we stop talking about facial palsy, in any patient that has a facial asymmetry, that can be the first symptom of them having problems swallowing. So in other words, there's trouble with that nerve tract, and they can be at risk for having dysphagia. So just kind of keep that in mind as well. Okay, and that's just a clinical thing. That's not for the stroke scale. But I gotta mix it up a little bit to keep you guys paying attention maybe. So the next one is motor. So what we're going to take a look at with this element is whether or not they can move their arm, their left arm and the right arm. Again, all we're looking at is motor response. And this is scored separately for the left and also for the right. So this is 5A and 5B. So you're going to have the patient, and you can have them do one arm at a time, or if the patient's pretty alert, cooperative, you can have them extend both arms at the same time. You just have to kind of see what works for that particular patient. But you have the patient extend their arms with their palms down, straight out in front of them, and hold for 10 seconds while you count out loud backwards, and see if they can keep those arms up. And again, we're making sure they have motor movement. If their arm dips whenever they first put their arm out or arms out, but it comes right back up again and they hold it for that 10 seconds, then that is still a normal, and you would give that a 0 for no drift. If the patient's arm drifts before the 10 seconds is up, but does not go all the way down and hit the bed, you give that a 1. If the patient cannot hold it up at all for the 10 seconds, it goes, they have some effort, but it comes right back down to the bed, you'd give that a 2. And if there's no effort at all against gravity, the limb falls, that's a 3. So in this situation, you would hold and support their arm up and encourage them to hold up their arm, and but they just cannot do it once you stop supporting it. And any time during this test, you can assist them with their arm placement, because you have patients that have arthritis, and you just have to kind of play it by ear. You can also pantomime it for the patient. If there's no movement at all in the patient, then that would be an automatic 4. And so your coma patient, if you raise up the coma patient's arm, and again, you're giving them the instruction, and you're going to say, okay, I'm going to raise up your arm, hold it up, and it's flaccid and goes right back down. There's no movement at all. That is a 4. This is untestable in a patient who has amputation or joint fusion. And again, you would not give them any points for this and not add it to the total, but write down your explanation of what's happening. So now we're going to go to a simulation video that we've been working on and take a look at motor assessment 5A and 5B. Now we're going to move on to 5 and 6, and we'll start off with 5, which is motor arm. And in motor arm, we're going to assess for drift. You can do this with your patient sitting up if they're able, or laying in the bed supine, either way. We're going to start demonstrating a normal or a 0 for 5A, or for 5, with our patient raising up her arms at 45 degrees and trying to hold them for 10 seconds. And what we're looking for is drift. Again, we'll show you first what 0 looks like. Okay, Sandy, I'm going to have you raise up your arms with your palms down. Excellent. And can you hold them there for me for about 10 seconds? Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, you can put them down. Thank you. That was a 0. She had no drift. She was able to hold up her arms at 45 degrees. I mean, depending on if she's laying down or in the chair, and she was able to hold it for 10 seconds without any kind of a drift. Now we're going to demonstrate 5 of the upper extremities, showing a 1, which means that her arm will drift, but it's not going to fall to the floor, and it'll drift down before the 10 seconds. Again, we're looking at both extremities. Now, if you have a patient that already has an injury or paralysis to one limb, then we would just assess the other limb, okay? So it's kind of, you're going to rate what you've got. Okay, Sandy, can you go ahead and extend both your arms, palms down? Hold those for me for about 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, thank you. So she had a partial drift on the left. So on this particular score, we would mark left arm, and we would give that a 1 for a partial drift. Now, if we were to demonstrate what a 2 looked like, a 2 is when there's some effort against gravity, but the patient's not able to hold that extremity up and it drops. Again, we're going to look at the left and the right. You can choose to do one extremity at a time depending on what's going on with your patient. So we'll see how she does with this one. Again, we're going to demonstrate what a 2 looks like. Okay, Sandy, can you extend both your arms with your palms down and hold them for me? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, good, thank you. And this time, she would have a 2 because she was making an effort against gravity, but she was not able to keep the extremity up for the 10 seconds, and it fell to the bed. So we would give her a 2 for that. Now we're going to demonstrate what a 3 would look like. A 3 is that the patient is not able to hold that extremity or extremities up at all, and they immediately will fall to the ground. Now, according to what's going on with your patient, if your patient is aphasic or stuporous, depending on how alert they are, depends on how much assistance you're going to give them. Obviously, if they're comatose and unresponsive, you're not going to do this test. But if they're semi-responsive, then you would support their limb and say, Sandy, I'm going to have you hold your arm up for me as long as you can, okay? So try to hold up your arm, okay? Now, I would do a better job if I supported her as she went down there. All right, hold up your arm. Okay, very good. And immediately it drops to the bed. And I would also check the other side. Now, Sandy, can you hold up your left arm for me? And her left arm may do better than her right. So we want to rate those separately. Again, both of those were 3s. There was no effort against gravity. They both fell. So a 3 on both sides, right and left. And then a 4 is no movement at all. So again, if I try to help her, encourage her, hold it up, and there's no effort against gravity, then that would be how you would rate a 4. Okay, so that's motor arm. Again, you have to use your judgment sometimes. If the patient has really bad arthritis, you do the best with the assessment. You follow the guidance and you rate it the best that you can. But again, it can be tricky sometimes. All right, we're going to go on to motor leg, which is very similar to motor arm. We're going to do the same test, but on the lower extremities, left and right again. Patient should be supine for this one. Have them extend their legs one at a time at 30 degrees approximately for about 5 seconds. So not as long for this one. Count out loud again and check and see if they can keep their leg raised. Whether or not it dips and then goes back up again, they can have that initial dip. But as long as it goes back up, you can give them credit for that if they can do it for the full 5 seconds. If they drift before the 5 seconds, but it does not hit the bed, then that's a 1. If it falls to the bed before the 5 seconds is up, but you can see them really trying to keep that leg up, you give them a 2. If there's no effort at all against gravity and the leg falls immediately, boom, to the bed, that's a 3. And no movement at all, that's a 4. Now your coma patient, again, you would give them a 4 for the no movement at all. But if you raise up their leg, give them instruction and they hold it because they're kind of on that, cusp of consciousness, you can score them a 3 for that. It just kind of depends on what's going on. This is another situation where if they have an amputation, of course, you can't assess motor strength and have them hold up a leg if it's amputated. So that's an untestable, or a joint fusion. Just put your explanation there. Okay, so let's take a look on the video of what it looks like for the motor. And it's kind of cool to remember that lesions of the motor cortex change sides. They cross over. They're contralateral. Okay, let's take a look at motor. Now we're going to do 6, which is motor leg. Similar to motor arm, except the patient has to be in a bed. We're only going to have them hold it for 5 seconds, and we're going to have them raise their leg to about 30 degrees. Again, we're going to check both sides and compare and score each side. Sandy, I'm going to have you raise your left leg about 30 degrees here. And can you hold it for me for about 5 seconds? Okay. 1, 2, 3, 4, 5. Excellent. You can relax. Very good. And let's check your right. And hold it for me. 1, 2, 3, 4, 5. Very good. You can relax it. So we would give that a 0 for normal motor strength in both of her legs. Okay. Now for a 1, it's very similar to the arm. She's going to be able to hold her extremity, but for the 5 seconds, but it's going to start to drift before the 5 seconds is up, but it won't hit the bed. Okay, Sandy, can you hold your leg for 5 seconds? 1, 2, 3, 4, 5. Okay, thank you. And now for your right leg, and for 5 seconds. 1, 2, 3, 4, 5. Thank you. So her left leg, we would score that as a 1, some drift, but it did not fall back to the bed. Now to score a 2, we're going to do the same thing again, and now she's going to have some ability to keep it up, but it will fall back to the bed before the 5 seconds is up. Okay, Sandy, can you hold up your leg for 5 seconds? Okay, thank you. And again on the other side. 1, 2, 3, 4, 5. Okay, excellent. So we would score this left leg as a 2. Okay, and that means there's some effort against gravity, but she was not able to keep it up for the 5 seconds and it fell back to the bed. Now we're going to demonstrate a 3, which very similar to the arm, there's no effort against gravity and the leg falls back immediately to the bed. Okay, Sandy, can you raise up your leg for me? Can you hold it there for me for about 5 seconds? Okay, thank you. And again, can you hold up your leg for me for about 5 seconds? 5, 4, 3, 2, 1. Okay, and so you would say on both sides of her legs, both her left and her right, we would give that a 3. There's no effort, no ability to hold those legs up. Okay. If the patient has no movement at all, we would score that as a 4. If the patient has an amputation of her lower leg or a joint fusion, again, we would label that as a 9, which means it doesn't count per se, but we would explain it. It counts, but we would give an explanation for that. Okay, and so my last statement there about counting, the untestable does not count. So that was just an error on my part there. So amputation or joint fusion, you would mark as a UN. On some of the scoring sheets, they have a 9. And so that's why that 9 or an X keeps coming up. And the reason it's like that is because the information is entered into computer programs. And so they can, in the software, they can say anytime they see a 9, a UN, or an X, for example, that means do not add, untestable. Okay, so that's motor. So let's go on to the next element, which is limb ataxia. Limb ataxia is only documented in this test if you definitely find it present. If the patient is in a coma or is paralyzed or cannot follow directions at all, you give them an automatic 0, no ataxia, okay? Because you have to have the patient to be able to understand you to see if their movements are coordinated. This is the one where you have them touch your finger and then touch their nose and then touch your finger again on both sides. They have to have their eyes open. They have to be able to be alert and cooperate with you to be able to do this. On the legs, so you do the arms and the legs, and for the legs you check both sides to see if they can take the heel of the opposite leg and move it up or down the shin. And you can do this with them in a chair, or you can do this with them laying in the bed. Most of our patients probably having an acute stroke are probably going to be in the bed. So you can help them and kind of demonstrate to them what you're wanting them to do. And pantomime, if they're aphasic, you can actually move their limb to show them as well. That's acceptable. So if there's no ataxia, they are coordinated in their movements in these finger nose to finger and heel to shin, then they get a 0. Or again, if they're in a coma or paralyzed for whatever reason, or they cannot follow directions for whatever reason, they get a 0. If they can follow instructions and their eyes can be open and they can cooperate, you check for ataxia and they have it in one of their 4 limbs, you give them a 1. If they have ataxia in 2 of their 4 limbs, you give them a 2. And again, untestable if they have amputation or joint fusion, and just document that information. Okay, so let's take a look at the video with this. Limb ataxia is taking a look at the cerebellum and or the connection to the brainstem.
Now for number 7, we're going to assess limb ataxia. And we're going to start off with showing what a zero is for absent limb ataxia. So Sandy, can you raise up your left arm and touch your finger to your nose? And then back out. And back to your nose. And back out. Okay. And you can go ahead and put that one down. And now can you do the same thing with your right arm? Finger to your nose, back out. And finger to your nose, back out. Excellent. So we would give both of her arms a 0 for that. No ataxia. But we're also going to check her legs. So now, Sandy, I'm going to have you take your right heel and move it up your left shin, just like that. Thank you. Excellent. So that's a 0. No ataxia in the right. Now can you do the same for your left? Move the heel up the left. Okay, very good. So she demonstrated 0 or absent ataxia. Now if she was in a coma or unresponsive, we would also rate this as a 0 because we would not be able to assess it otherwise. Now to show a 1, that means one limb has ataxia. So it could be one of her upper extremities or one of her lower extremities. And if that was the case, we would give that a 1. So Sandy, we're going to do the same thing again and demonstrate a 1. All right, can you go ahead and raise up your left arm and touch your finger to your nose? Back out again, finger to your nose, and back out again. Okay, now can you do the same thing with your right? Raise up your right arm and your finger to your nose. Okay, all right, very good. And now I'm going to have you check your legs. Can you take your right foot and move it up your shin on your left? Very good. Now can you take your left heel and move it up the shin on your right? Excellent. So she has a partial or one limb that has ataxia, so we would score that as a 1 for present in one limb. Now if it's present in 2 limbs, we would give it a 2. So no ataxia is a 0, one limb is a 1, and 2 limbs is a 2. So we're going to do the same thing again, Sandy. Can you raise up your left arm for me and touch your nose? Very good. And back out and touch your nose with your finger. Excellent. And back down again. Okay. Now how about with your right arm? Can you raise up your right arm and touch your nose? Okay. All right. Now can you take your left heel and move it up your right shin for me? Very good. Down again. Now try to see if you can move that right heel. Okay. All right. And you move that right heel up? Nope. Okay. Thank you. So we would give that a 2. So she's got some hemiparesis on this right side, and that's 2 limbs, so we would give that a 2. Okay, so that was limb ataxia. Now, if the patient has an amputation or a joint fusion of one of her extremities or both, we could score that as a 9, and a 9 means untestable. All right.
Okay. So I just want to point out on that demonstration, I did not have her touch my finger first and then touch her nose and then touch my finger again. So for the upper extremities, I did not do a great job finding out if she had coordination. She did a great job with what I asked her to do, but I just didn't ask her to touch my finger. But in the simulation, you will see that where the patient is asked to do finger, nose, finger on both sides as well. The other thing with that is too, if the patient has a total loss or complete hemiparesis, then that, as I said, you could do it's hard for them to do anything, and that would be a 0 for that. I think I said something wrong at the end of that last clip, so I wanted to be sure that was explained. Sorry about that. All right, so now let's go to the next element. Oh, this is just a picture from the Ontario Stroke Center about what it looks like to do finger, nose, finger. And honestly, sometimes we don't do the stroke scale very often. I know for a while I worked in a neuro unit in Missouri, and we did them all the time. This was back when we were first doing TPA for ischemic stroke. And I didn't have to always try to remember exactly how to do it. But now, since I've had kind of a gap between doing it, I definitely would like to have this picture in my stroke folder. And there's no reason why I couldn't make a copy of it and laminate it and put it to help guide me, to help me remember how to test limb ataxia appropriately. Even though the instructions on my sheet said finger, nose, finger, that picture really helps, I think. Okay, so we'll go on to the next slide and talk about sensory. So when we're taking a look at sensory, all we want to know here is, what does the patient feel? We're not really trying to find out anything else except, can they sense or feel the sharp movement? Sensory and motor complications are very common in stroke patients, and they usually have to do with dysfunction of the parietal lobe or sometimes the thalamus. And so we see this a lot. So we're going to tell the patient to close their eyes. We're going to use a sharp object, and we're going to compare the one side to the other and touch them with the sharp object and instruct them and ask them, well, first tell them to ask them to close their eyes and say, I'm going to touch you with something. Can you feel this? And then do it on the other side and say, does it feel the same? Can you feel this? Does it feel the same? And you're going to start at the face, go from left to right, work your way down. You can either do trunk or arms or a little bit of both if there's any doubt, and then go down to the legs. Now, the patient in the simulation is a standardized patient, so she's not a patient. She's an actress and also a nurse, by the way, and she's quite excellent. Cheers to Sandy, because she is an amazing actress and nurse. But you can adjust, you need to adjust their clothing. You don't want to go through clothing to assess for this. But I did not check her thighs because she's a standardized patient. So I just wanted to mention that. You use a pinprick and a sharp instrument and observe the reactions. If the patient is in a coma, you can still assess for this. And I've had this happen before with a patient that was unresponsive, and I did this test and the patient yelled at me. I've also had patients try to hit me. And so that is definitely someone feeling the pinprick. Again, you don't want to hurt the patient, so you're not actually pricking their skin. You're not making a mark. You're just using, in the example that we have here in the video, I use a paper clip, but the instructions do say a pin prick, but do not actually prick the skin. So if they have no sensory loss anywhere, they can feel all of these, and they feel the same, then that's a normal. When you're doing this testing, if you get to an area where the patient doesn't feel anything, or maybe they're aware that something's there, but they can't really describe it, or it feels different than the other side, or they're not reacting at all, no matter what's happening. So one, mild, if they're aware, maybe it feels dull instead of sharp in comparison to the other side. That's a 1. And a 2 is severe sensory loss. The patient's not aware of being touched at all. And so your coma patient is an automatic 2, because they may posture, but they're not, it's not a sensory, it's not, you can't really compare it from side to side, and it's not due to the pinprick. And it's not a purposeful movement in a coma patient. It may be a posturing, reflexive type movement. So that would be a 2. Okay, so let's take a look at a clip. And I do want to explain that follow what I'm saying, not necessarily what I'm doing in this video clip. You want to compare side to side at the same time. Whereas in the video clip, I started on one side and then went all the way down and up the other. So we'll go ahead and start that.
The next section, section 8, assesses sensory. We're going to use a sharp object, preferably something that won't actually hurt your patient. I'm going to use a paper clip, and we're going to test whether the patient has feeling or not, essentially. So we're going to first demonstrate a 0 or a normal, which means no sensory loss. Sandy, can you close your eyes, and then I want you to tell me if you can feel this, if you feel anything.
Yes.
What's it feel like?
Something sharp?
Okay.
Yes.
Tell me if it changes. Still feel it?
Still sharp.
Okay. We're going to go down. I'm telling you that, not her.
Sharp. Sharp.
May have to take your...
Sharp. 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 Sharp.
Okay. And we're still going, Sandy. Same thing. Tell me if you feel anything and what it feels like.
Sharp. 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 Sharp.
Okay, thank you. You can open your eyes now. So that is a 0. She could feel sharp everywhere that I tested.
Mm-hmm.
Now, if you have a doubt, so for example, if there was something that she wasn't quite sure on, then you can go a wider range and check the forehead. You could do more of the trunk, if you need to get more specific if you have any doubt. Now, we're going to start on the same side this time, and we're going to do the same thing again. And this time we're going to demonstrate what a 1 would look like. A 1 would be that I do the same thing, but it's not always, she doesn't always feel it, or it may feel dull. So it's a partial sensory deficit, okay? So Sandy, I'm going to have you close your eyes, and I want you to tell me if you can feel anything.
Sharp.
What's it feel like? Sharp? Okay,
Sharp.
good.
Sharp. 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 Just barely dull. Dull, maybe. Dull, really. Dull. Maybe dull. Dull, maybe. Dull.
Okay. I'm just going to go to the other side. You're doing great, Sandy. Okay. Again, tell me if you feel anything and what it feels
Sharp.
like.
Sharp. 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 Sharp.
Okay, you can open your eyes. All done with that. You did great. So that is sensory 1. There's a mild change. There's some sensory loss on her left side there. She could feel something, but it didn't feel sharp. She thought that was dull. Sometimes she didn't feel it very well at all. So definitely some sensory changes there. So now we're going to demonstrate a 2, which is a total or severe sensory loss, where the patient's not aware of being touched at all. So again, we're going to do the same thing again on the face, the arm, and the leg this time. And a 2 would also be what you would rate a patient in a coma. as well. A patient may respond with posturing or grimacing or withdrawal, but that would still be rated. Again, a 2 for a coma. If the patient was aphasic and stuporous and trying to tell you, you can tell that they can feel it, you would give them a 1, okay, if that makes sense. Okay, so one more time, Sandy. Okay, all done. Thank you. You did very.
Okay, so just to clarify a couple things, the easiest and the best way to do this for the stroke scale is to stay on one side of the patient and compare side to side. Again, you don't need to assess the hands and the feet. I got a little carried away at times and kept on going, but that's not really a part of this test. And we want to make it as quick and as accurate as we can and as easy on us as we can as well. Also, I want to clarify one more thing that I said on the video. And the patient that is confused or difficult, having trouble, you can still do this test on them and observe the reactions, even if they can't cooperate. Again, they may withdraw or hit you or move away or give you a bad look, but they felt it. So you're looking only in this test whether they can feel it, not their level of consciousness, in other words. But if they're in a coma, automatically give them a 2 because they can't tell you what they feel. The other thing is, don't ask them whether it's sharper or duller. Just say, can you feel this? And then go to the other side, and does it feel the same? Okay, let's go on to the next one. Number 9, best language. I'm definitely having challenges with my language and my throat today. And I've been telling everyone, the more I'm studying about stroke, the more difficulty I'm having with my body. So I think I'm gathering the symptoms as I go. So best language takes a look at the aphasia, whether or not the patient has it. You're going to show them 3 different things. You're going to show them a picture and ask them to describe it. And these are testing sheets that NIH provides online that you can have printed out and laminated and have with your stroke scale. But the first one is a picture, and you ask them to describe what's happening, and you're looking for comprehension. What can they tell you what's happening, and what is their language, and do they understand what's happening? Both of those things, really. And the second testing sheet, you're going to have the patient name the items that are there, and there's different objects for them to name. The third sheet is just a list of sentences, and you have the patient either read those sentences or repeat those sentences for you. This one is an exception to the first response rule because you're encouraging the patient in a way and assisting them, because you want to know, are they comprehending even if they cannot get the right word for it, in other words. So you're looking for both expressive and comprehension here. You're not looking for slurring. We're going to look at that in number 10. But what we're looking for here is, do they know what it is, and do they have a word for what it is, in other words. So the way you score this one is 0 is a normal. They're fluent, there's no aphasia at all, they can converse with you, they can tell you about the picture and describe it, etc. A 1 is for mild aphasia, and this means that over 2/3 of the time, 2/3 or more of the time, they've got everything correct in these 3 testing sheets. They're fluid. They can comprehend what they're seeing. There may be some reduction of speech. They may forget some words, but they can make conversation related to these testing sheets. That's a 1 from mild aphasia. A 2 means there's severe aphasia. And most of the time, the listener is trying to help and guess and question as to what they're trying to say. There's a lot of inference going on by the listener, and they may have some of the words right, but most of the time, 2/3 of the time, they are not able to tell you what's going on in these 3 testing sheets. So that's why in a patient that has some aphasia, you want to go through the 3 testing sheets in a row to try to give yourself as much time to be able to figure out how much aphasia that they have. And then a 3 is automatic for any patient that is in a coma or has no speech at all, or comprehension. That's automatically a 3. So be sure and give them their glasses if they wear them. Hearing aids, of course, we probably should have given them the hearing aid from the beginning. Turn on the lights, set them up in the bed. It's nice if you have a clipboard. Sometimes hard to find these days in a hospital, but get them all set up so that they can see it pretty well. And you can use your assessment of visual fields to help you to understand how much assistance this patient's going to need with vision. Obviously, if they're blind in part of their eye, you're going to put the testing sheets in the area where they can see them, move that to that area where they don't have the blindness. I'm not going to try to say hemianopia. Okay, JJ, let's go ahead and start the video for this. Language is a common problem with patients having stroke. Remember the Wernicke areas are over on that left hemisphere, but some people do have those speech areas on their right hemisphere. Let's take a look.
Number 9, we're going to assess best language. So we're basically looking for aphasia here, both the spoken word and comprehension. I'm going to show Sandy this picture, and I'm going to ask her to describe it to me. First, we're going to demonstrate a 0 for no aphasia or normal. Hey, Sandy, do you need glasses, or can you see that okay?
I can see it.
Okay. Can you describe to me what you see in the picture? And just take your time.
Looks like the little boy's on a stool and he's going to fall to get his cookies. And this might be his sister. She sees he's going to fall. She's going to help her catch the cookies, one. Mm-hmm. And this is the mom washing dishes, and she's left the water on too long and the floor's getting all wet.
Okay, excellent. Okay, so she showed a 0 for comprehension of the picture. And now we're on the same part of this test. I'm going to show you some objects, and I'm going to see if you can name these for me. And here's the picture of the objects. Okay.
A glove,
Mm-hmm.
a key,
Mm-hmm.
cacti, a chair, a feather, and two trees with a hammock.
Okay. A hammock sounds like a good idea.
Mm-hmm.
And the last part of this test, Sandy, is I'm going to have you read these sentences for me. And hopefully you can see those okay.
Down to earth, I got home from work. Near the table in the dining room, they heard him speak on the radio last night.
Very good. So we would score Sandy a 0, no aphasia, normal. Now let's demonstrate what a 1 would look like. So a 1, we're going to do the very same test again with the same pictures. And a 1 means there's mild aphasia. Okay, Sandy. I'm going to have you take a look at this picture. Can you see that okay?
Yes.
I can adjust the light if we need to, and you've got your glasses on. Can you tell me what you see in the picture? Describe it to me.
A boy and girl. washing dishes.
Good. Okay. Anything else? Okay, very good. Now I'm going to show you some pictures, and can you tell me what you see?
Teeth, hand, trees, chair, feather, swim.
Now I'm going to have you read these sentences for me. Can you read that for me?
Down to earth,
Good.
I go to work. On the table, I heard the radio.
Okay, thank you. Very good. Okay, so that was an example of a 1, mild or moderate aphasia. So now we're going to demonstrate a 2, which is severe aphasia, with the very same test. Sandy, can you describe what you see in this picture? Cookie jar. Looks like the little boy and little girl. Like he's gonna fall. Very good. Yeah, she's washing dishes and having a spill, isn't she? Okay, very good. Now I'm gonna have you look at some pictures, and can you tell me what this is?
A bird.
How about this one?
Car.
Okay.
Car.
Okay. What about that?
I don't know.
Okay.
I don't know.
Okay. Okay. Good. And now I'm going to have you read some sentences for me. Can you see that? Okay. Okay. Can you read this one for me? What's that say? Good. Does that say, I got home from work? Okay. Okay. Very good. Very good. Thank you. Okay, so that was an example of how you would score severe aphasia. That was a 2. Okay, very good. And then a 3 is when the patient has global aphasia and or is mute. Okay, so again, we'll do the very same test again and see what response. There's no usable speech or any comprehension. Sandy, I'm going to show you a picture. Can you tell me what you see? See the picture? See the cookie jar? Okay, that's fine. No problem. I'm going to also show you some objects. See if you can tell me what these are. What's that? Okay. How about this one? Okay. Is that a key? Okay. And then I'm going to see if you can read some sentences for me. Can you read this sentence for me? Can you see that? Okay. See that? Okay. Very good. Thank you, Sandy. Okay, so that we would rate as a 3. So mute, global aphasia, no usable speech or auditory comprehension. Okay, very good. So any of those you would rate as a 3.
Okay. So you can see that our actress Sandy is quite excellent. She does a really good job demonstrating the aphasia. Okay, we're going to just scroll through the different pictures, and we've just got the 3 of them to go through real quick, and then we're going to go on to dysarthria or articulation, which is number 10. So articulation or dysarthria is looking for slurred speech. And in this one, you're going to have the patient read a list of words or repeat the words from the attached list. This is different than aphasia. In aphasia, we're looking for, do they comprehend and do they have the language? Do they know the word? And oftentimes, the patient may comprehend, but they don't have the word, or they have the wrong word. And that's the aphasia. In dysarthria, we're looking only here for speech clarity. And you listen to their words, and you can't really, if they cannot read for whatever reason, then you can see if they can repeat words from the list for you. Again, this is all about listening for speech clarity. We'd rate a 0 for normal. 1 is mild dysarthria, so some of the words are slurred and other words difficult for you to understand. And a 2 is rated for severe dysarthria, slurred and unintelligible. In other words, they may have dysphagia and have severe dysarthria along with it, but it's out of proportion to that dysphagia. Patients that are mute, you would rate as a 2, or have no words at all, you would rate as a 2. Patients that are comatose, again, a 2. And patients that have garbled speech, but you can't understand any of it, it's all garbled, you'd also give as a 2. This is one you can do untestable if they're intubated or have any other physical barrier that will not allow them to speak, because again, you're not wanting to know whether they know or if they have the right word this time. Now you want to see if they have clarity or absence of slurring, essentially. So we're going to take a look at a video, again, looking at the quality of speech or looking for dysarthria. In the latest guideline update, they did call it articulation, but calling it dysarthria is still correct as well.
Next section is section 10. We're going to assess dysarthria or slurred speech. First, we're going to show you what a 0 looks like, which is normal. Sandy, I have a list of words here for me. Just want to see if you can say them and repeat them for me. Can you see this okay?
Yes.
Okay.
Mama, tip top, 50-50, thanks, huckleberry, baseball player.
Thank you.
Excuse me.
Now we're going to demonstrate what a 1 would look like, which is mild dysarthria or mild slurring. So some words will be able to understand and some we may not be able to. Okay? Again, Sandy, can you read this list for me of words and repeat them?
Mama, tip top, 5-5, thanks, baseball player.
Excellent. So we would rate that as a 1. And a 2 would be severe dysarthria or slurred speech, and we would not be able to understand any of the words, or there may be no speech at all. Sandy, can you see this list for me?
Mm-hmm.
Can you read this word for me? Or any of these words? Good. Very good. Thank you. So we would rate that as severe dysarthria or a 2. Now, if your patient was intubated or had some other type of physical barriers that they could not speak, maybe a trauma, something like that, you would give them a 9 or a UN for untestable.
Okay, so again, that one's all about quality of speech and listening to them repeat. We're going to go on to the next slide and take a look at the final element. It's called extinction or inattention. It used to be called neglect, and inattention is, essentially it means neglect still. It can be a very serious safety problem if your patient has extinction or inattention, because they may not be aware of a body part that's in trouble, And so that's it's something to always take note of if you have a patient that has this. I've had a patient before after a stroke who would maybe have their affected hand or arm underneath of them. And you have to be very careful when you position and turn them, because they're not aware of that arm or limb, that it doesn't get injured. You have to kind of keep an eye out for them because they're not aware of it. So we're going to take all the information that we've used for all these other elements in the test, and we may be able to tell already without doing anything further whether or not the patient has extinction or inattention. If there's any doubt, you can do testing with double simultaneous stimuli testing. Now, small thought to maybe make you laugh. Do you remember Animal House? Or if you've not seen it before, there's a part in Animal House where they're talking about that particular fraternity house is on double secret probation. So every time I see double simultaneous stimuli or stimulation, I think of Animal House and it makes me laugh. So sorry about that. I hope it makes you laugh too. So the way you do double simultaneous stimulation testing is that you are on both sides. You're testing both sides of the patient at the same time. First, you're going to test whether or not they can see you. And the next thing you do is you have them close their eyes, and then you touch them on one side and then the other and then both sides to see if they can feel you. You can have them raise up an arm or say where they feel you at or give you some kind of indication. But it's all about awareness. This is all about inattention, awareness, and trying to find out if they have anything that they're neglecting. Neglect can be associated with parietal damage, parietal lobe damage as well. And I was going to say one more thing, but I think it left me. If the patient is aphasic, but still is paying attention and attending to both sides when you're doing this testing, maybe they're raising up the arms appropriately, etc., you can still give them a normal for that as well. So I wanted to be sure and share that with you. So the way you score this is if there's no abnormality, they get a 0. So this is similar to ataxia. If it's absent, there's no score, there's no points for that, no abnormality. If they're in a coma, because they can't tell you if they're aware or not, or show you the results of the double simultaneous stimulation, then you'd also give them a 0 as well. If when you're doing the testing, there's mild loss in one of the sensory modalities, so for example, maybe in one area of maybe they can't see out of their left in one quadrant over there, that would be a 1. Or maybe when you do the testing, they cannot feel anything on their left side, that would also be a 1. So one sensory modality is lost, and that could be in the visual field or the tactile field. A severe loss is counted as a 2. 2 sensory modalities lost, and that means they may have profound inattention to one side of their body. They may not recognize their own hand, or they may only orient to one side of space. And sometimes these folks do not even perceive that there's something wrong at all. And they have that that lack of awareness, essentially. So again, this can be a real safety risk for your patient. But when you're scoring your patients, keep in mind that you may already have gathered this information when you're doing all your other testing, and you might be able to score this pretty quickly. All right, let's go ahead and start the video on this. So again, it's okay. You're not assessing whether they can count or whether they have strength. What you're looking at is attention.
For section 11, the last part of the stroke scale, we're checking extinction and inattention, which was formerly called neglect. This one can be challenging to do in a patient that has some deficits. But first we'll show no abnormality. most of the time when you've been doing your stroke scale, you've already picked up on whether this patient has inattention or extinction, and we could go ahead and score her without doing anything further. But we'll go ahead and test her with the double simultaneous stimulation to show that she is normal. Okay, I'm going to put my hands up, and when you see that, I want you to raise your arm on the same side, or if I raise up both arms, raise up both your arms, okay? Okay, now we're going to do the same thing, except I'm going to have you close your eyes, and I'm going to touch your leg, one side and then the other, and then both sides together, and raise the arm on the same side,
Okay.
or both. Okay, very good, thank you. So we just demonstrated no abnormality, or a 0. Now we're going to demonstrate a partial, which is a 1. Hey Sandy, I'm going to put my hands up in your peripheral vision, and I want you to raise your arm on the side that you can see, either one or both.
Okay.
Okay? Ready?
Mm-hmm.
Okay. Now I'm going to have you close your eyes, and when you feel me touch your legs, raise your arm or arms up on the side that you can feel it. Okay, ready? Okay, so that would be a 1. So she had one deficit, a visual deficit on the left. We'd score that as a 1. Now to demonstrate a 2, that means there's 2 deficits, okay? Either from visual, tactile, the different fields that we're assessing. All right, so we're going to do the same thing again. So just look at me again, and when I raise up my arms, raise up the side of your arm that you can see that. Okay, now I'm going to have you close your eyes, and when you feel me touch your legs, you were already responding. I was touching you early. When I touch your legs, raise up your arm on the side or the sides where you can feel me touching you. Okay, so we demonstrate a 2. So we had a deficit in the visual field and the tactile field, and we would count that as a 2. All right, and so that is the end of the number 11. Okay, we made it. We're just going to go back for just a couple slides, and then we'll be ready to move forward to the simulation. So just have some informational slides at the end that talk about the severity and what it means, and also just a few resources for you, just showing you here. And we will have this available to you once we get all our references plugged in. You guys will have access to these slides and the information. Okay, JJ, over to you.
Yeah, and I was just going to share that as well. We will get the PowerPoint to you at some point in the near future. We'll give it to the folks at IHA Shelby Hornback, and they will then get it to your facilities so you can have access to the actual PowerPoint itself. A couple things I wanted to mention real quickly, because it is we're focusing mostly on the assessment through the NIH Stroke Scale, but there were a few questions within the pretest that I wanted to cover real quickly before we go on to the simulation. So a few things that you need to know, is that the big thing for us when somebody is suspected of a stroke is to get them to CAT scan as quickly as possible. The reason being that we want to determine whether or not the person is having a hemorrhagic stroke or an ischemic stroke. We do know that 80% or around 87% of all strokes are ischemic in nature, and so those patients are eligible for fibrinolytics therapy, and therefore CAT scan is the main thing we want to get to. You don't want to delay anything for the CAT scan when the CAT scan is available, and that includes the stroke scale. We want to get a neurology consult as quickly as we can as well, but make sure that that CAT scan is not delayed. In addition to that, we know that we have to exclude folks if the time frame from time zero is determined, and so the quicker we can get the CAT scan done, the better. If a person has had head trauma within the previous 3 months, that is one of the exclusion criteria for giving thrombolytic therapy, and so that was one of the pretest questions that you'll want to know. One of the things that that we posed on the pretest were signs and possible signs of possible stroke symptoms. Sudden severe headache with no known cause is definitely one of them, but also sudden trouble walking and trouble speaking or understanding. Those are all signs and symptoms of stroke. The question on the pretest was posed: if there was a patient that woke up from sleep with symptoms of stroke, when is time zero determined? And the answer is when the patient was last seen to be acting normal. So we don't, when they first wake up, that's not time zero. The time when the patient fell asleep, if you don't know that they were acting normal before that, that is not time zero as well. So it's the last time that the patient was seen acting normal. And that doesn't have to be from a healthcare provider. It's just from somebody who witnessed the time. For the 8 Ds of stroke care, the answer for that was that detection, decision, and drugs were all components of the 8 Ds of stroke care. With the Cincinnati Pre-Hospital Stroke Scale, and Suzanne will kind of talk about this a little bit, I think, in the simulation, the things that you're looking for in that are facial droop, arm drift, and abnormal speech. And then one of the things that is a common cause of stroke is arrhythmias. If somebody does not have a history of atrial fibrillation and they went into atrial fibrillation, that can cause clots to form in the heart, which can then be thrown out into the brain, causing an ischemic stroke. And so if anybody has new atrial fibrillation and some other arrhythmias as well, then that's something that needs to be taken into account. And if somebody starts having neurological changes, that would indicate that. If somebody has atrial fibrillation and they've been on a thrombolytic or a blood thinner for an extended period of time, they have a less likelihood of having a stroke. But still, anytime there's atrial fibrillation present, you got to be thinking that might be causing the problem. So with that, we're going to go into the virtual simulation now, and please watch. And as we complete that, start thinking of some questions that you might ask for both of us as when we finish it. Go back just a little bit so you can read that. There you go.
Yeah.
Sandy? Hey,
Yeah.
I'm Suzanne. I'll be your nurse today. How you feeling?
A terrible headache.
How long have you had that headache?
Actually, about 3 days of it's worse now.
Okay. I'm going to check your blood pressure, and we'll see how that's going. And I'm going to put that, it'll be squeezing your arm every so often, so don't be alarmed.
Okay.
Have you been taking anything for the headache at all?
Just Tylenol.
Shut your eyes for a second. I'm going to turn on a bright light so I can see how you're doing here. Okay. Can you look at me? How you feeling? Don't look like you feel very well.
No.
Are you sick to your stomach?
No.
You having any pain anywhere else besides your headache?
No.
And you kind of pointing up here to your
Right.
right side. Can you rate it for me on a scale from 0 to 10? 0, no pain, and 10 is the worst imaginable.
Probably a 7.
Probably a 7. Has it gotten worse here in the last few minutes?
Oh, since I woke up,
Okay.
about 4.
Okay. Anything else feel different at all?
No.
Not that you can feel anyway? Okay.
Mhm.
Can you squeeze my hands for me? Okay. Alrighty. You can release that. All right. Can you open up your eyes and raise up your eyebrows for me? Okay. I can tell you have a bad headache. I'm sorry about that light. I'm just going to check your pupils with my light. Can you open and look at my face? Just hold your head still. Very good. What pretty green eyes you have. All right. Will you stick out your tongue for me? Excellent. Can you show me your teeth? Very good. Can you shrug your shoulders? Just lift those up. Okay. Excellent. Okay. Have you had any weakness on that left side before?
No.
Okay. And how about your legs here? How are they feeling? Any pain in your legs? Your feet? No? Can you push up against my hands? Okay. Can you push down? Okay. All right. I'm a little concerned that this left side is a bit weak, Sandy.
Can't really feel it.
Yeah. So let me get some help, and we'll get the doctor called, and we may need to get you down to have a scan done of your head, okay?
What's going on?
I'm not sure, but we want to make sure that there's nothing wrong. So we want to rule out that there's, we want to make sure you're not having a stroke, quite honestly, okay? Let me get some help. Help. Whenever you get time, will you bring in some stuff for Coach Stroke?
Yeah.
All right.
Do you need a page in there?
Yeah, Paige, neurologist on call and intensivist. Dr. Sampson, I think is her doctor.
Okay.
Thanks. All right, I'm just gonna shut the door while she gets that for me. How you feeling? About the same?
Yeah.
Okay. Just gonna listen to you and see how your lungs and heart sound. Take some deep breaths for me. Excellent. Do you feel short of breath at all? No? Good. Very good. All right. Well, thank you, Laura. She's got some new left-sided weakness and a pretty bad headache.
Okay.
So I think she probably needs to go down for a CAT scan. And I'll go ahead and start doing the stroke scale.
All right. I called Samson and he's in ER.
Okay.
He didn't act like he was going to come up right now. Do you want me to get any
Yeah, we
orders from
yes, we probably do need our stroke orders
him? Okay.
and probably the thrombolytic checklist we
Okay.
need to start. I'm gonna
Does
go
she have
ahead.
an IV and everything already?
She's got one IV, but you might want to get stuff to start a second
Okay.
one. That's a good
All right.
idea.
I'll call him back and then
Okay.
I'll be back in.
Okay, thank you.
You're welcome.
All right. Sandy, is it okay if I go through some questions and check you over a little bit more closely? Okay. All righty. Can you tell me what the month is?
December.
And can you tell me how old you are?
67.
And can you open your eyes again and then close them real tight? And then open them? Good. And also, I'm going to have you make a fist around my fingers on this right hand. Good. And let go. Okay. And this side. Okay. I can feel you trying. Thank you for that. Ready? And now I'm going to have you follow my finger. So just keep your head straight and look at my nose. And I'm going to have you follow my finger from the left to the center and then to the right. So just follow with your eyes. Ready? Okay. And then. Very good. Now I'm going to do the same thing, except this time I'm going to go up and down on both sides. All right? Again, just keep your head still and only move your eyes and follow my finger. Okay, thank you. Now I'm just going to have you do a few more things for me. Can you show me your teeth? Good. You can relax that. Raise up your eyebrows. Alrighty. Now squeeze your eyes real tight. Shut. Okay, very good. Thank you. Just going to check your arms. Can you hold up your right arm for me with the palm down? And just hold it there for about 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, you can relax it. Okay, now I know that this left arm is feeling heavy. Can you lift that up at all and hold it out? Okay, that's fine. Thank you.
I having a stroke.
That's what we're going to find out, and if you are, we're going to try to get some medicine in to stop it, okay? We'll have really good success using the clot busters to get rid of it. But the CAT scan will show for sure. And you know, sometimes you can have a TIA, so we don't know yet. That's what we're going to find out. I'm going to check your legs now. We're going to do kind of the same thing that we did with your arms. I'm going to have you raise up your right leg and just hold it for me for 5 seconds off the bed. 5, 4, 3, 2, 1. Very good. And I know this left side's been giving you some trouble, so let's try raising it up again. See if you can raise that up at all. Okay. Now you try and see if you can raise that at all. Does it feel numb?
Yeah.
Okay.
Heavy.
Heavy and numb. It's going to be okay. Hang in there, okay? We're going to get you fixed up. You're going to be going to CAT scan real soon, all right? And your blood pressure's staying about the same right now. It's still a little too high, but it hasn't gotten any higher, so that's a good sign.
What is it?
It's about 168/90. How's your headache?
Same.
Same? Okay. All right, now I'm going to have you take your right heel and move it up your left shin. Very good. Cute. Now we're going to do the same thing with the other one. Try to take your left heel and move it up your right shin. Okay, that's okay. And now I'm going to have you, I'm going to write this down before I forget though. Okay, and
Dr. Sampson said he would be up after the CT was done.
okay, very good. I'm almost done with the stroke scale, so we can tell him.
Okay. CT said they'd be ready in about 5 minutes.
Oh, that'll be perfect.
They were actually already here. Have you gotten a blood sugar yet?
I have not, but that's a great idea.
Okay,
And
I'll grab this
also,
stuff.
does she have any orders for blood pressure?
For
Like
management of her blood
yes.
pressure? I believe so, but I'll look in her chart.
Okay.
And what's her blood pressure running?
It's running around the 168/90.
Okay. And lab will be here to draw some blood.
Okay.
Just a few.
Maybe a 12 lead.
12 lead?
Mhm.
Okay.
Thank you.
You're
Alrighty. Now, I'm going to have you raise up your right arm and take your finger and connect it to my finger. Now connect it to your nose. Just touch your nose. Now my finger and your nose. Good. Okay. And I know this is a heavy arm. Still feeling about the same? Can you raise it up at all? Nope. Okay. All right. You're going to be going down to CAT scan here shortly. All right.
Okay.
All right. Now I'm gonna see how your sensory or how you're feeling things. So you tell me if you can feel anything, and then tell me what it feels like. Go ahead and close your eyes, and I'll be starting at your head and working down towards your feet on both sides.
Okay.
All right.
Sharp. 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 Sharp.
And Laura's gonna check your blood sugar.
Sharp. sharp.
You're doing great. Just anytime you feel something, let me know. Okay, done with that test. Thank you.
Ma'am, I'm gonna clean up your finger here, okay?
Now we're gonna do some language testing, okay? It won't take long, and there's a picture I'm gonna have you look at first. You need your glasses on. Excellent. Is that? I know that light's bright. So alrighty. Can you just tell me what you see in the picture?
Boy and girl and Jesus.
Good.
Not off there. Blood sugar's 188.
Okay, thank you. 188. Okay, and can you tell me what you see in this picture? Describe these items.
Blurry hand, tree, and pencil.
Okay, fine. Okay. And then can you read these sentences for me?
Down from work,
Yep, down to earth.
from work,
Yep, I got home from work.
cable line,
Right.
radio.
Okay. One more language. And this one, I just want you to read some words for me. You see those okay?
Blurry.
A little bit blurry, okay. Have you been having blurred vision at all?
No.
No? Okay.
Mom. Tiptoe. Fly. That. Berry. Baseball.
Thank you. Okay. All right, hang in there, Sandy. One more test, and then we'll be done with this part, and we'll be getting you ready to go to CAT scan, okay?
Okay.
All right. Now I'm going to have you look at, you want your glasses back off? Okay, let me take those off for you. All right, can you take a look at my face and just keep your head still looking at me? And I'm going to put up my hands, and I want you to tell me what side you see my hand at, okay? It could be left, right, or both. Ready? Okay. Now can you close your eyes for me? And I want you to tell me, or lift up the hand, whichever is easier for you, where you feel my hand at, okay? Okay. All right, you can just relax now. You want me to turn that light back off?
Yes.
Okay. Okay.
EKG's ordered.
Okay.
CT's ready now.
Okay, she needs to go then.
Okay.
Okay.
All right, can we grab a portable monitor?
Yes, please.
All right. Are you all finished with your?
All finished with the stroke scale?
All right. Did you want me to go down with you?
Oh, do you have time?
Yeah.
That would be great.
All right.
Where are you going?
We're going to take you down to CAT scan, and it won't take long at all, okay? We're going to also put another IV in. And you haven't had any, have you had any procedures lately?
No.
Did you have a heart cath not too long ago?
Yeah.
Was that last week you had a heart cath?
I don't remember.
Okay. And are you on blood thinners at home?
I think so.
Yeah, I was thinking that you were too. Well, we'll check through all that. Okay. Okay, you just lay there and rest. You want your glasses?
No.
Okay. We're ready to go. Do you want your glasses?
Let me go back right there. So initial CT scan results were unremarkable, and Mrs. Withers was transferred to a higher level of care. CT the next day showed an ischemic stroke. After a week in the hospital, Ms. Withers still has left-sided hemiplegia and dysphagia. She was transferred to an extended care facility for rehabilitation. All right, so now we want to open it up and talk about this scenario. And so hopefully all of you are still on the line and you're still awake and you're ready to talk a little bit with us. And so we'd ask that you take your microphone off mute. And if you have any questions for this, now would be the time to do so. But also I would like to know what you thought of the simulation. What kind of things were done well in this simulation? Anyone? All right. Well, we can talk about this a little bit. So Suzanne, are you on there?
I'm here.
What were some of the things that you saw in the simulation that you'd like to point out as being needed, and why you did some of the things you did during the simulation?
The patient had new left-sided weakness. She'd had the headache and the hypertension, but she didn't look good. And then when I did the brief, kind of like the Cincinnati scale, she definitely had weakness in that left side, and she just wasn't looking too good. And you could see throughout the simulation, she was starting to kind of even get worse. I went ahead and was kind of doing a brief tiny neuro assessment and otherwise assessment while waiting for the stroke scale to come in, and found out at that time as well that she had the little bit of speech trouble start to show up. She also had some facial, maybe very minor, it'd be hard to tell whether or not she had facial asymmetry, but looked like it maybe mild as well. So we went ahead and started the stroke scale. Most important thing is to get her to that CAT scan as soon as possible, and to try to get that baseline stroke scale while we're waiting for the CAT scan to be ready or on the way, but you don't want to hold the CAT scan. And Laura had a great point getting that, getting the blood sugar checked to make sure we didn't have a blood sugar that was too low, because that is sometimes can mimic a stroke as well. And her blood sugar was 188, so that was okay. Anything else, JJ, that you want me to go through? Interestingly, she had AFib when she came in, and so she was on, and also had just had a heart cath and a new stent put in. So that's the reason why the physicians decided not to give her TPA or get TPA started. They also decided not to send her somewhere for thrombolectomy, those types of things, because her platelets, when we checked, were only 88. And so that's a contraindication to doing the TPA. So that's kind of why that decision was made as well. I did want to point out that I did the visual field test a little bit differently here. I probably should have done it more like I did when I was later checking for neglect. I was doing that extraocular movements, but I'm trying to pretend I'm not, but I'm trying to pretend like I'm Julia Child and I meant for that to happen, but I really didn't.
One thing I'd like to
go ahead.
kind of ask about, so with all of our folks on here, you're all from critical access hospitals. How might this be differently handled within your facility?
Would.
Did you hear any of that?
We did not, no.
Okay, they said they would call a condition H. They would have a physician in-house because we have an ER doc here. And then so they would get down to CT pretty quickly, whether they're coming from the outside in or they're upstairs down. So we do have that availability pretty quickly.
And are you typically able to get your CAT scans done fairly quickly?
Yeah, yeah. But it doesn't seem to be an issue here.
Yeah. How often are you given thrombolytics?
We got one ER nurse in the room and she says not very.
Not very often, okay.
No.
And so with the stroke scale itself, would you have done anything differently, or are you guys using the stroke scale in these situations?
They said that the only difference would be that they would go faster.
Yeah, well, we're kind of doing it slow on purpose just to just to make sure everybody sees every component of it, right?
Yeah, yeah, for sure. So what's the golden time on that? Is there any kind of a measurable standard that we should be
As soon as
aiming
possible.
towards? I know as soon as possible, but how long should it take to complete that scale?
There is no golden standard for that. I researched it and it just says as soon as possible.
I've seen some neurologists do it in 5 minutes, and I've seen some people do it in 15. So
Yeah, I think we were kind of slow on it because we don't do it very often. Maybe the people in the ED do it a little quicker, but Patricia's got something she's wanting to say over there across the room.
sure.
So her question is, if they start the scale, then they interrupt it, take them to CT, and they bring them back, do you start at the beginning or do you start where you left off?
Oh, you do the scale before the CT. So,
Yeah, we wouldn't hold up the CT for that though.
no,
right?
you would not, but you'd be doing it en route. And you have enough time to get it done before you get to CT, almost always. But you want a baseline before you do any interventions. So let's say you started it and you don't quite have it, you could continue it after the CT, okay? But really you want the baseline before the CT, then the CT, all, like you said, very quickly. Depends on the timing, but you could resume it if everything goes that fast.
So what we're doing here is if they call that in on the rig, the CT's ready, they take them straight to the CT. We don't play that CT at all, so.
That's appropriate.
Yeah, that's very good. That's even better. But you want to do the stroke scale before you do any intervention. So
Okay,
that's the goal.
okay.
Get that baseline in before you give them anything or give them TPA or anything like that.
It's going to really help the neurologist know what part of the brain is involved in the stroke. And so knowing what kind of deficits they have before and after that is going to help make a determination of maybe how long they're going to have problems potentially.
Yeah.
Anybody else out there want to ask a question?
We've kind of had people scattered through the hospital listening and watching, and then we had a room full in here, and then, yeah, so we had good participation. I didn't know how it was going to fly like this, but.
We're doing our best to do this virtually. It's much better for us to be in person. But even those who are not able to attend live like this, we're going to have the video recording so people can watch it later at least.
Well, we appreciate that.
Yeah.
It's very scary to have a camera watching you. You could see I was so red, I was about to explode.
I wondered what your blood pressure was.
Exactly. I thought I was having a stroke. I don't like to be filmed.
None of us do either. None of us are good actresses. We are if there's no camera on, but bring the camera on, forget it. Everybody clams up, so.
But they kept telling me we're simulating real life and real life is not perfect. So you're going to make mistakes. And I did. So there you go.
Yeah.
Just in case I had some nicardipine over here in my office, I was going to take you.
Well, good to know, I guess, for Suzanne's steak over there.
I need help.
Well, so real quickly, I want to go ahead and give you the information so you can take the post-test and do our evaluation. And you don't necessarily have to stay on the line to complete these, but I will leave it up here for a brief time so you can do that. It's very important for us and for the Indiana State Department of Health to have pre and post tests and evaluations. So we want to make sure that these get done. So
Okay.
I'll leave these up here while we're asking some other questions, if anybody does have any questions further here.
Okay.
Anything else you want to add, Suzanne?
I think the one thing I want to stress is that the stroke scale is good at what it does, but again, it is not a complete neurological exam. So you still want to do your other exam once you get that stroke scale in and they're in CAT scan or on their way. You keep doing your other stuff and implement those orders or whatever your facility uses for care of the acute stroke patient rule out. So I thought that was really interesting. All these years, I've been doing the stroke scale for a long time, but I've had kind of a gap now because I'm not taking care of patients like I was. And I tell you, practice really helps with this. And I remember when we were filming the simulation, I hadn't really looked at it very much at all because I had done this so many years for so long. I thought, I got that, no big deal. But then I looked at the explanations. I'm like, what? So I think that having those hints in your stroke packets are a good idea. It helps me to see the picture of exactly what that is. Sometimes when I'm stressed and my patient's not doing well, if I look at a bunch of verbiage, I may not interpret that like I should as quickly. And in that case, if you have another colleague that can help, like I was very lucky that Laura was able to come in when she did, but that's just a good case for practicing and reviewing the stroke scale so that when you have to have it, you know how to do it quickly. So that's something I just wanted to share. The other thing is there any barriers that you guys have to anything with the stroke scale or any other questions with the stroke scale? I did add a couple of references that really I thought were helpful. And one was the what do you do if the patient's in a coma or is confused or uncooperative. You have those patients that are trying to hit you. You do the best you can. So we attached that as well. But please let us know of any barriers or questions. I'm really curious because, like I said, I did this for many years and I taught it for many years and then I had a gap. So I kind of want to know, what are the things that really bug you about it that are your questions, etc. Anyway, thank you. I hope you guys are doing great. Hope to see you in the flesh eventually sometime soon.
Well, we sure appreciate you guys doing this.
I would like to add also that, you can do simulations like these on your own and practice doing the stroke scale. All you need is somebody that can lay in a bed and act a little bit. You don't have to be a great actor, but I think doing the scale, like Suzanne said, is very important and practicing it over and over again, because the more you do that, the quicker you're going to be at it and the better you're going to be at it. So you don't need us to do simulations like that. You can do it on your own.